Urinary tract infections are among the most common bacterial infection encountered in the outpatient setting and in long-term care facilities worldwide. Given this prevalence, optimization of antibiotics for urinary tract infections is a common target for antimicrobial stewardship programs. Cystitis and pyelonephritis are considered complicated when there is an increased risk for failure of therapy as the result of anatomic abnormality, urinary tract obstruction, or infection with a multi-drug resistant pathogen, or the patient is pregnant. Most urinary tract infections in men are considered complicated due to limited penetration of many antimicrobials into prostatic tissue. 1/2 or more of women will develop a urinary tract infection during their lifetime. Given the availability of guidelines, this discussion only deals with uncomplicated infections in women. We discuss catheter-associated urinary tract infections and asymptomatic bacteriuria in our companion course. Urine culture is unnecessary for diagnosis of uncomplicated cystitis in women with compatible symptoms. Greater than 90% of patients who have dysuria and frequency and abnormal urinalysis in the absence of vaginal discharge or irritation have a urinary tract infection. If there are, however, reasons to suspect infection with an antibiotic-resistant uropathogen, such as recent antibiotic exposure, most commonly considered exposure in the preceding 3 months, or international travel that may have exposed the patient to drug-resistant organisms like ESBL-producing Enterobacteriaceae, obtaining a urine culture should be considered. Urine cultures should also be obtained in patients with suspected acute pyelonephritis. Follow-up urine cultures for test of cure are not indicated in patients with either acute cystitis or pyelonephritis whose symptoms resolve with antibiotic therapy. As many as 95% of cases of uncomplicated cystitis and pyelonephritis are caused by E. coli, with most of the rest due to other Enterobacteriaceae or, predominantly in sexually active young women, Staphylococcus saprophyticus. The predominance of E. coli means that its local antibiotic susceptibility pattern dictates the optimal choice of empiric antibiotic therapy. This, of course, makes the choice a moving target as antibiotic resistance to widely utilized agents becomes increasingly widespread. In the patient with uncomplicated cystitis, the Infectious Disease Society of America guideline recommends empiric therapy with either nitrofurantoin for 5 days, trimethoprim sulfamethoxazole for 3 days, a single dose of fosfomycin, or pivmecillin, which is not available in the U.S., for 5 days. Trimethoprim sulfamethoxazole should not, however, be prescribed if greater than 20% of uropathogens are locally resistant, or if the patient has received this combination in the previous 3 months. Fluoroquinolones are a second-line choice and should not be used if greater than 10% of local uropathogens are resistant. Beta-lactam antibiotics, other than methicillin, have a higher rate of failure, and their use dictates closer follow-up. The choice among the recommended antibiotics should be based on local susceptibility data, host factors such as allergies, and cost. Ciprofloxacin, administered orally for 7 days with or without an initial intravenous dose, ceftriaxone, or an aminoglycoside, may be used in empiric therapy of uncomplicated acute pyelonephritis in the outpatient setting. One of the latter two should be used in lieu of ciprofloxacin if greater than 10% of local uropathogens are fluoroquinolone resistant. If the implicated pathogen is known to be susceptible, orally administered trimethoprim sulfamethoxazole may be administered for 7 days with or without an initial intravenous dose of ceftriaxone or an aminoglycoside. Therapy with a beta-lactam is inferior to the other choices and, if used, should probably be administered for 10 to 14 days. Patients may have bacteriuria in the absence of symptoms. With the exception of pregnancy and perhaps a few other circumstances, asymptomatic patients should not be screened for the presence of bacteriuria, and, if detected, they should not receive antibiotic therapy. This is true regardless of the presence or absence of pyuria. Not only is antibiotic therapy in such instances not warranted, recent evidence suggests it may actually be contraindicated. In a study of a large number of asymptomatic young women with recurrent urinary tract infections randomized to receive placebo or antibiotic therapy because of the presence of bacteriuria, the relative risk of recurrence of symptomatic infection was greater than threefold higher in the antibiotic recipients. Likewise, asymptomatic candidiuria should not be treated routinely with antifungal agents. The IDSA candidiasis guidelines suggest that antifungals should only be considered for patients with asymptomatic candidiuria with a high risk of disseminated infection, such as in neutropenic patients, infants weighing less than 1,500 grams, or those undergoing imminent urological manipulation. Of note, this strong recommendation is based on low-level evidence. For those interested in more information on this topic, we discuss catheter-associated urinary tract infections, asymptomatic bacteriuria, and mimics of UTIs in our companion course, available online.